Hello everyone, this is Dr. Adam Stewart. I'm a family doctor and I'm here with another video. I'm going to try to show you what happens when the government tries to make substitutions for family doctors. And with this continual erosion of family medicine, just to point out, one of the main points is here that there is no substitute for a family doctor. And when you try to make substitutes, the result is disorganization, an inefficient healthcare system that's more costly and has lots of unintended consequences. So this is just coincidentally right on the heels of yesterday's news on July 24th, where Ontario is exploring more options for expanding the role of pharmacists, which, to be clear, I don't really have a huge problem with. But this is quite a coincidence that this happened on the very same day that Sylvia Jones made her announcement. So I have a patient, and an elderly patient, late 70s, early 80s, just picture that range, a man, and he was recently diagnosed with a bit of stroke symptoms in June of 2024, so about a month ago. And the stroke specialist, he has diabetes, but it's fairly well controlled. But the stroke specialist was making some optimizations, so added atorvastatin, which is a cholesterol pill, and a sitagliptin, which is an additional diabetes medication. So that was June 17th. And just to point out, this patient, like all of my diabetics, is followed regularly for me, every 3 months, routinely for routine diabetes care. A little bit of a graph here in June, around the time of that visit. This patient's A1C happened to be 7.1, which is right around the guidelines, quite fine for arguably what would be an 8.5 target in an elderly person. And these fluctuations here, you see, they might have never. I think that was a 7.6 last year, like pretty well controlled for years. And again, this patient is part of my diabetes program care, which on my website I proudly display my diabetes and all my healthcare metrics that Health Quality Ontario provides me with. You'll see that my care far exceeds the provincial average in terms of diabetes monitoring, retinal testing, and this is even in a rural area, by the way. And statins is on par. As a little side note here, I'd say that my statin prescriptions are maybe a little not exceeding the provincial average, like my other metrics are, for two reasons. One, an impoverished patient population with a lack of drug coverage, but also because when I talk about cholesterol pills with patients, I practice shared decision making, meaning that I tell the patients, here are your risks of without taking the cholesterol pill, here are your risks reduced by taking the cholesterol pill, and I let patients make their own decisions on what is individually right for them. Little aside here related to pharmacies, I wonder if my prescription rate for statins would be higher if I personally stocked cholesterol pills and kept them in my exam room and was able to have a markup and selling fee every time I prescribe my patients a statin. But I'll let that sink in for another discussion. In any case, this patient in question had his routine blood work done. Here we see July 22nd, just a few days ago, and in fact is due to see me next week for his routine diabetes care, which we'll review all this, follow up on the stroke clinic, all of that. So as you can see, a pretty well cared for patient. So I was very surprised to see this. I never saw this before. I noticed from a Shopper Drug Mart pharmacist that they had done their point of care testing and cholesterol checks on this patient, just I guess randomly, so again, this is a person who's already having blood work done by me, that blood work is being charged to the Ontario government by the labs, and then I am going to see the patient for diabetes care, for which the province pays me as the family doctor to take care of this patient and his diabetes, and yet the pharmacy is now charging the government for a point of care test for a redundant A1C test, that's the sugar test, and cholesterol checks. And again, this is right in the middle of me seeing the patient next week. So totally redundant, disorganized, inefficient. what's really weird is this, this follow-up. Patient will return to follow up with it for another A1C test with the pharmacist in 3 months. I leave it to you, the public, and the patients. If someone has a family doctor who's doing very good diabetes care, who's the best and most appropriate person to care for this diabetes? Should the patient be following up with the pharmacist in 3 months and me? Should the government be double paying for this work? I don't know. And here's the other thing: not all diabetes care should just follow simple algorithms and guidelines. Because if you actually look at this person was again just started on a cholesterol pill and new diabetes medication a month ago. It takes 3 months, 2 to 3 months, for the A1C sugar test to change. So it's too early to even check for this patient to have another check anyway. And then also, per the Canadian Family Physician cholesterol guidelines, which I also have posted on my website, including a direct link to their guidelines. You'll see that actually, if a person is actually on a cholesterol pill, the evidence and the science and the simplified guidelines show that if a person started on a cholesterol pill, there's no need to ever retest cholesterol, and that is per the Canadian Family Physician guidelines. It's a little bit too much to go into why that is and why that makes perfect sense in this little video, but feel free to explore this link on my website and dive into the discussion. I've tried to break that down in layperson terms. So again, I just found this kind of very alarming that coincidentally on the same day that we're talking about expanding roles for pharmacists, and I'm going to rephrase that, trying to find more substitutes for family doctors, that we have this clear example of inefficient, costly care with unintended consequences.